Welcome to This Explainer. Today, we're diving into one of the absolute most fascinating microscopic mysteries in all of pathology. We are going to be medical detectives tracking down a silent, highly evasive systemic killer known as amyloidosis. It's a crazy journey that's going to take us from bizarre macro-level physical clues right down to the nitty-gritty molecular level. So, picture this. What in the world links completely unrelated symptoms like heart failure, a swollen tongue, and carpal tunnel syndrome? I mean, you probably think they have absolutely nothing in common, right? But as a medical detective, asking this exact kind of question is your very first step to catching a hidden culprit. When a patient shows up with this seemingly random constellation of failing organs, alarm bells really need to start ringing. And the answer to our puzzle? Amyloidosis. It's a rare disorder caused by the extracellular deposition of insoluble, abnormal fibrils that just totally wreck your tissue. Basically, normally well-behaved soluble proteins kind of lose their minds, misfold, and clump together into this biological trash. Fun historical fact, actually. The term comes from amylum, which is Latin for starch. The famous pathologist Rudolf Virchow coined it way back in 1854 because he originally and mistakenly thought these weird deposits were basically just starch. All right, Section 1, the medical mystery. Let's start by looking at the physical evidence left behind at the crime scene. Just take a look at this. This illustrates the real human stakes. Macroglossia, or an abnormally enlarged tongue. This happens because those misfolded proteins are physically accumulating right there in the soft tissues where they absolutely shouldn't be, just stubbornly taking up space and throwing off normal function. But, the clues aren't just hiding in the mouth. We see really bizarre systemic signs too, like nail dystrophy. It just goes to show that this microscopic rogue doesn't just hang out in one organ. It completely and systematically disrupts the entire body, from your heart all the way out to your fingertips. Moving right along to Section 2, hunting for clues. Let's zoom out and look at the macroscopic signs. Way before a pathologist ever even touches a microscope, they can spot the damage just with the naked eye. When an organ gets infiltrated by amyloid, it physically transforms. The organs get noticeably larger, way paler, and super firm. And if you were to cut into them, the edges are strangely waxy and sharp. The rogue protein is essentially turning living, pliable tissue totally stiff. Now, to confirm these suspicions without any magnification, pathologists use a really cool old-school forensic trick. They apply Lugel's iodine, which literally turns the amyloid deposits pitch black. You can see it perfectly here in a heart that was suffering from restrictive cardiomyopathy. Basically, the stiff amyloid locked up the heart muscle so it couldn't pump. It is just such a wildly clear visual confirmation. Okay, Section 3, catching the culprit. Time to bring out the big guns and look at the microscopic evidence. So, under a standard H&E stain, amyloid is super sneaky. It hides right in plain sight as this pale pink, amorphous, eosinophilic stuff. I mean, sure, it looks suspicious, but we definitely can't base a definitive conviction on just that. We need harder evidence. And that is where our heavy hitter comes in, the gold standard Congo red stain. This stuff specifically binds right onto the amyloid and dyes it a really deep, vibrant salmon pink. It is an absolute game changer for chemical proof. But here is the absolute aha moment of the whole investigation. When you take that Congo red stained tissue and throw it under polarized light, boom, you get this dazzling, almost glowing effect known as apple green birefringence. The physical structure of the amyloid actually interacts with the light. When a pathologist sees that glowing green, it's case closed. The culprit is, without a doubt, amyloid. If we really want to look our villain in the eye, we zoom in with an electron microscope. And there they are. Rigid, non-branching fibrils, barely 7.5 to 10 nanometers across. They just stubbornly pile up, completely resisting the body's natural attempts to sweep them away. So why are they so impossible to get rid of? Well, it all comes down to the villain's ultimate weapon, a specific molecular sheep called the beta-pleated sheet. This is the unifying feature of every single type of amyloidosis. This exact folded structure is what creates the Congo red reaction, it builds that rigid fibril ultrastructure, and most terrifyingly, it totally resists proteolytic digestion. Meaning, your body's normal cleanup enzymes literally cannot break it down. All right, Section 4, profiling the three major types. Now that we know the weapon, we need to profile the specific gangs involved. Since over 30 different proteins can form amyloid, pinpointing the exact one is absolutely crucial for the patient's survival. Let's compare the big two. First, the AL type. Think of this as a rogue plasma cell factory, just churning out immunoglobulin light chains, often tied to myeloma. Then we have the AA type. This one's secondary, driven by serum amyloid A in response to severe chronic inflammation, like if a patient has rheumatoid arthritis or tuberculosis. Same deadly structure, entirely different origins. And then we have our third suspect, hereditary amyloidosis. This is where a genetic mutation, like one messing with a transport protein called transthyretin, inherently programs your own body to misfold its building blocks. Another wild example is familial Mediterranean fever, which actually drives the AA type due to constant genetically triggered inflammatory attacks. In these cases, the blueprint for the disease is literally hard-coded right into the patient's DNA. Which brings us to Section 5, stopping this supply. We've got the evidence, caught the culprit, so how on earth do we stop it? The entire treatment strategy revolves around cutting off the supply chain. Step 1, you've got to reduce the supply of those precursor proteins. How? By aggressively treating the underlying disorder. That might mean chemo for the myeloma in AL cases or potent anti-inflammatories for AA cases. And for those genetic cases, doctors might actually perform a full-on liver transplant just to swap out the main factory that's producing those variant proteins. But despite these massive efforts, the reality of this disease is pretty sobering. As the source material notes, quote, however, still a dismal prognosis in general, therefore early diagnosis and awareness of potential amyloid is crucial, end quote. It really highlights exactly why clinicians have to be incredibly vigilant medical detectives. Time is basically the ultimate enemy here. Which brings us to our final critical takeaway. Once these rogue proteins take hold and lock into that beta-pleated sheet, they are there to stay. The body just cannot break them down. So it really makes you wonder, if we can't undo the damage, how many lives could we save if we just learned to spot those seemingly unrelated macroscopic clues? The swollen tongue, the unexplained heart failure, the waxy skin, just a little bit sooner. The mystery might be solved under the microscope, but the real battle to save the patient, that starts by connecting the dots in the clinic. Thanks so much for joining me on this explainer. Keep asking those vital questions, and I'll catch you next time.